over there, and he's an excellent deformity surgeon who had his training in Halifax in Canada with famous Ron Hawari. He's going to be talking about dreaded complications in deformity correction surgery, just because you want to get us depressed at the end of the day, Masoud. So just go ahead, please.
Thank you so much. Again, happy to be here in Fujairah. Thank you, Dr. Wael, and the organizing committee. Thank you to the moderators. Thanks, Dr. Sameh, for the introduction. So I'm going to be talking about some dreaded complications. Believe it or not, all happened in one case. So one case for me. Hopefully this one case will be enough to scare you guys away from deformity surgery. But I hope to win you back towards the end of it. So anyhow, without further ado, let's get started. No disclosures for me for this talk. So the case I have for you is a case I encountered courtesy of Dr. Ron during my fellowship. And this patient, she's a 17-year-old girl, history of kyphoscoliosis, no back pain, no neurology. Physical exam, she's neurologically intact. She has a high BMI, body weight's 106. This is her imaging. You can see the standings. It's quite significant kyphoscoliotic deformity going on. And this was back in September. That's the preoperative CT scan. So again, you can see here very, very significant congenital deformity, which is what I would say is a recipe for complications and disasters. So here we go, that's the pre-op CT scan. Again, for better visualization. She also had a pre-op MRI, which essentially showed what we kind of expected. There wasn't anything abnormal apart from a small syrinx, and she also had this extreme kind of kink in the cord that's coming where you kind of can see the apex of your deformity. Okay, and so for this kind of case, we always have to ask our question, ask the question, why do we want to operate? Why don't we just leave her alone? And essentially what this is, it's a kyphosis mainly, but also associated with the scoliosis congenital. There's a failure of segmentation. And the usual reason that we operate is because of the natural history of these kinds of curves. They tend to develop progressive paraparesis and obviously worsening deformity. So the surgical plan for this patient was a two-stage approach. Stage one was an anterior approach, left thoracotomy, T12 to L1 vertebrectomy, halofemoral traction for 2 weeks, and then this is all followed by stage two, which is a posterior spinal fusion, T4 to L4, laminectomy and decompression at the apex, and also an interbody fusion. So a lot on the grocery list for this patient. So stage one, September 29, so anterior approach, thoracotomy, vertebrectomy, application of halo. So far so good. These are the x-rays, can't see much, but not much was done in the first stage. So again, she was placed on traction at about 12% of her body weight for 2 weeks. This was followed by stage two, October 13. Like we said, posterior spinal fusion, instrumentation, T4 to L4, laminectomy, interbody fusion with cage and bone graft. Unfortunately, during the correction, there were monitoring changes, loss of MEP, loss of SSCP bilaterally during the correction of the kyphosis. As predicted, like we said, this kind of deformity with this kind of high BMI patient is a true recipe for complications and disasters. And at the time, this was kind of the algorithm, and of course, it's always important for any deformity department or deformity surgeon to have kind of a plan or approach or an algorithm that he's going to follow when he loses signals. So, not to go much into detail, but you can see kind of in the past where the wake-up test was part of the algorithm. I think the newer algorithms out there published in the literature, most recent one I think by Mike Vitale from New York, and these don't really include wake-up tests, I think, because neuromonitoring sort of replaced that. But essentially, to sum up this algorithm, if you have improvement, you can keep going. If you don't have improvement, you have to make checks, check in with anesthesia, check in your correction, keep kind kind of checking to see if you're going to end up with an improvement or not. And then you take the decision if you're going to continue with the surgery or if you're going to send the patient to the ICU, at that specific time. And so, for when that happened, of course, there was optimization of blood pressure, temperature, and hemoglobin. The kyphosis correction was released. MAPs and SSCPs thankfully returned to normal, took about 16 minutes, and they remained normal for the remainder of the case, which was about 2 to 3 hours. The post-op examination, the patient had bilateral weakness. Left was worse than the right. There was also decreased sensation. Again, worse on the left side than the right side. Arranged for urgent imaging, but not much was identified, apart from artifact. So this is the x-ray at this point in time. You can see, again, how the correction looked like. So maybe not the best correction, but definitely better than what we started with. The post-op neurology exam, you can see how the right side wasn't doing too bad, 4+3, left side a bit worse, so some of them were 4. But you can see that hip flexion, and of course dorsiflexion of the foot. And EHL, you're still 1 out of 5. And her sensation was gradually improving on both sides. So again, there's some more algorithms for you if you're interested, but this is for delayed neurologic injury and also about what to do really when you're faced with these kinds of complications in the post-op period. So as you can see, you can consider, check your hemoglobin, check temperature, check the MAP, consider steroids, check for improvement, imaging, of course, CT, MRI, and based on the findings, you can consider returning to the theater, or you can continue ICU management for the patient. So for this patient, she was admitted to PICU. In the post-op period, we started her on methylprednisolone, good course of steroids, and we maintained her MAP more than 100 and her hemoglobin more than 11. So there was mild improvement over the next kind of day or two, but not much, in terms of return to her baseline. So she still had weakness in mainly the left lower limb, very slightly in the right lower limb, and decreased sensation mostly over L2L3 dermatomes. And so again, repeat imaging. So there was a very small hematoma above the gel foam, maybe mild stenosis at the laminectomy site, but not much other findings. Neurological exam wasn't really improving after that initial improvement, so the decision was taken to bring her back to the theater for hematoma evacuation, extension of the laminectomy, possible screw exploration exchange. And this was done on October 15th, where there was some evacuation of the hematoma and the gel foam. Laminectomy was extended, screws were checked, 2 crosslinks were added to protect the canal at the site of the osteotomy. And that's the x-ray after the second, or I should say the third surgery for this patient. Post-op, she continued to improve in terms of her neurology, but unfortunately, October 27, she had sersanguinous drainage, so started IV antibiotics, dressing changes, her wound continued to drain. She had her first IND November 3rd. You can see how it looked pretty bad. Unfortunately, multiple INDs, November 3, 5, 7, 9, 11, 15, and finally closed the wound over drains. That's what things looked like on November 11th. So essentially, she grew all these organisms. I don't even know how to pronounce some of them, but it is what it is. Antibiotics. With the help of the ID team, she was put on, again, tons of things: vancomycin, meropenem, caspofungin, amphotericin, piperacillin, tazobactam. So there was also fungal infection going on. So really, really bad time for this patient, unfortunately. December 6th, that's what things looked like. Yeah, you can see here. Post-operatively, she lost 7 kgs, she needed TPN, and she developed DVT in the left leg. Clinically and on ultrasound, she was put on enoxaparin for 3 to 6 months, by the medical team, and she also had an IVC filter insertion. And this was the IVC filter insertion, December 8. And that's, I think, the end of the road, and after many months in June, the patient thankfully was able to ambulate, and she did graduate, and she did get her high school diploma, so happy ending for her. This was her x-ray 4 years down the line, so you can see maybe not the best correction, but thankfully things are holding up, and she didn't have any other complications after that. And so, to go through some of the literature, so this was published in 2008 in the Scoliosis Journal. It was a systematic review, and essentially you can see that the rates of major complications is quite high, and the pooled rate of complications is also quite high. So neuromuscular scoliosis, for example, 35%, in adult 44, early onset 48. And if you look at the major, again, quite high, 17, 30%, 8.6. Congenital is a bit better here in this study. And then if you look at, for example, death, there's 6.5% neuromuscular scoliosis, deep wound neurologic complications was reported as 7.5 in adolescent scoliosis, etc. So quite significant, I would say, risk of complications. Another study, big study, multi-center on adult spine deformity, and again you can see quite a big percentage, and mostly as patients get older and more frail, they experience more risk of complications, whether it's shock, death, urologic complications, other things, infections, etc. And this is kind of the final one that I'm going to show. This was also a big study published in Spine Deformity. 19,360 cases were kind of reviewed. Very big names in the author list, like Chris Ames, Chris Shaffrey, etc. And this was sponsored by the SRS M&M committee. And you can see that what they reported here was that the overall complication rate was 10%. There were higher rates of morbidity and mortality with neuromuscular cases and congenital cases, which is kind of what we expected, and a bit better for idiopathic, but even idiopathics, they do have a 6% risk, which is, again, quite significant. And so they also mentioned that there's high rates of new neurologic deficits, more associated with aggressive osteotomies like pedicle subtraction osteotomies and VCR, which is vertebral column resections. Compared with pedicle screw only, hook only construct, wire only anterior screws were more associated with risk. So pedicle screws have the lowest risk. And you can go into the detail of that, so you can see kind of how the breakdown is. Neuromuscular higher, there's a risk of death, etc. Durotomy, implant related. So there's really a whole grocery list that you can look at. If you look here, for example, mortality, there's more risk of mortality with neuromuscular patients, but it's also significant in congenital patients, and that's probably related to the amount of bleeding, osteotomy that you need to do, and the medical comorbidities that the patients have preoperatively. And you can see here in terms of neurologic deficits, while it may not be extremely high, it is, again, not insignificant if you do many of these cases, or if you do many of the complex cases, because these would have higher risks. And unfortunately, when you look through kind of, incomplete, complete, nerve root deficit, etc., even as you look at the breakdown, you notice that not every patient has a complete recovery. Some of them do, some of them partially recover, and a few of them unfortunately experience no recovery. So there is a real risk, and sometimes regardless of how you manage these patients, you may not get the best outcome. So what do we want to take home? Risk of complications of spine deformity correction surgery is significant even in the best centers and with the top surgeons. A meticulous and careful pre-op workup and planning is very important to mitigate the risk. Patient education is crucial before surgery because it can help prevent litigation and other problems, and it can keep you on good terms with with the patient and the family. Managing complications is quite difficult, but it's very, very important for final outcome and prognosis. Thank you very much.
Thank you.